Welcome to another episode of SSF Live. Today on the panel, we have Dr. Shane Tubbs. We also have Christian Fizan. Welcome to the panel today, guys.
Thanks, Ricardo.
Thank you very much, sir.
For sure. What exactly will we be watching today?
So today we have Dr. Rod Oskouian, and he's going to be performing something called an extreme lateral interbody fusion. And this is a fairly new technique that's used to fix the spine in folks who have disease. And instead of doing the traditional approach from behind or from in front, this comes in from a lateral or a side approach.
Right. So is the purpose of going in through the side, is that to decrease the rehab time or the...
Sure. So it's a minimally invasive procedure that allows you to go through a much smaller incision and get to the same structures inside that you need. So Dr. Oskouian is going to go through, and he is an expert on doing this procedure, which takes a lot of training and is not for mere mortals. So he's going to walk us through and show us exactly how he does it.
So we're going live now to Dr. O. How you doing, Dr. O?
I'm doing great. Thanks, Ricardo.
Awesome.
It's a pleasure being up here with you guys.
For sure, for sure.
So I'm going to walk through what we're going to do, and you can see here we've kind of marked on the X-ray that we're going to go between the vertebral bodies and then in that disc space. So at this level, we're doing the third lumbar vertebral body, and then you can see that we've kind of marked it there with an X-ray. And this is the actual size of the incision, so it's the size of my thumb. And so we're going to go ahead and start. So we'll make a small incision.
So for the people, Dr. O, who
Yes.
might don't know that, the patient is lying on the side?
Yes, that's correct, Christian.
Okay.
So the patient, so this is the patient is lying on the side, and this is the belly, and this is the back. And the head is up here, and the legs are down below. And so we just made a very small, tiny incision. And as Ricardo astutely pointed out, the nice thing about this approach is that the rehab time is very minimal. In fact, most patients go home the next day. So we make a very small incision, and we go through this corridor and land on the spine. But to get to that, what we do is we kind of open this up. Let me get a little retractor. Do we have like a little Wheatlander, Steve? And so we just very gently, and you can see here there's not very much cutting. So all the muscles that we go through here, Dr. Tubbs will detail every muscle that I go through in a lecture later on in the year. So we put a little retractor down, and we go through all the muscles, and then let me get a dilator.
So how did you identify the level of surgery?
So we marked it. We kind of cheated a little bit. And through X-ray, we kind of marked it. And then do we have, let me see, do you have like a peon or actually one of those curved? Right there, perfect. Thanks, Steve. Awesome.
So
now,
Dr. O, is this a common surgery, or is this something that happens, 1 in a million, 1 in 1,000? Is it, what is the likeliness that the average person watching this will have this surgery?
Yeah, that's a great question, Ricardo. So it's not that common. It's common in my practice because I do a lot of this procedure. In fact, I do it mostly for patients who have, let's say, like a fracture. So, for example, I did it for a patient on Saturday that had a fracture or a tumor, and you can see how small of an incision this is. Mm-hmm. Literally through these dilators, we're able to. Let me see the. Perfect. And then the key to this approach is that it's minimally invasive. So patients go home literally the next day, and then come on in, Tyler. Let's get a quick shot. And you can see here, literally, I'm already down on the spine, and we're gonna monitor as well. So while I'm doing this, there's nerves. We have to map what's called the lumbar plexus. So the nerves go through this muscle called the psoas muscle. And so now we're going to get an X-ray, and then come towards me a little bit, Tyler. Okay, great. So we'll get a
So
shot
for what
there.
was this little cable you clipped on there?
What's that, Christian?
For what was this little cable you clipped on
Oh
the
yeah, so
probe?
So the probe that we put on is so this stimulates the dilator here, shot there, Tyler, and then so now we're able to actually look and see one more shot. Okay, so let's see the K wire. Come on out, Tyler. Feels like we are. Yeah. Okay. Yeah, that's true. Okay. So let's see the mallet. Okay, come on and let's do a quick lateral. So what this does is this safely gets you through the lumbar plexus, and that's what we were doing there. Is so this little wire, this little clip, essentially monitors the nerves, so we can safely go past the nerves, and you can imagine the nerves kind of go through this. It's like the LA freeway here. So you have to safely dilate through the nerves. And then once you dock on the lateral aspect of the spine, so you can see here we got a little bit more to go. So we're going to go down and then shot there. And then let's see the mallet.
Rod, other than the lumbar plexus, what structures are you most anxious about staying away from?
You know, fortunately, we don't have to worry too much about the abdominal organs. Shot there, Tyler. But that can be, you know, initially, it's interesting. So I've been doing this for about 10 years. And when we first started doing it, it's such a unique procedure that it's just not a normal approach that we take. So going in the retroperitoneal space is actually not something that we're really trained in. So go ahead and turn on the nerve monitoring. And you can see as I go down, I'm basically making this corridor bigger, and then I'm also watching to see where the nerves are. And so...
How do you know for sure that you're in the retroperitoneal space and not in
Oh,
peritoneum?
that's a great question, Shane. So the reason why I know it is because on X-ray, we go just above the iliac crest, and then when I was doing it, you pop through the retroperitoneal fascia. So once you do that, then you know you're in the retroperitoneum. Shot there. And actually, I remember the first time doing this, I was really nervous because I had never really been in the retroperitoneal space before. Shot there. Okay, great. So now we got and then the numbers here tell us, so it's going to be about 120. Okay, perfect. So now we've got, so you can see just the size, it's like the size of my thumb. Essentially, we've now docked on the lateral aspect of the spine, and you can do so much through this little port and go right down, and
And with the probe, you're now on the intervertebral disc space?
Yeah, so we're now on the lateral aspect of the disc space, and you can see it here we'll see it on the X-ray. So go ahead and shoot that. Okay, so we're going to push it down a little bit more. There we go. Perfect.
Rod, how do you know if the kidney and the ureter are out of your way?
So the ureter, that's a common question that people have, is the ureter is more anterior to where I am, and then the kidney is anterior and superior to where I'm at. So I've never had an issue with either one, but the traditional approach would be, you know, you'd basically make an incision. We would call it the Sharkbite incision. It would be the entire incision would be right there, shot there. And so oftentimes when we would do that approach, we would actually have to identify the ureter, and you can oftentimes see the kidney. So it's really, this approach has been revolutionary. Shot there. Great. And
Have you ever had any complications, like in terms of bowel injuries or like injuring the urethra?
Yeah, so I've had every complication you can think of. But I think, for me, I haven't had, knock on wood, I haven't had a bowel injury or a kidney injury or a urinary injury. But the most common complication you have from this approach is damage to the nerves and the lumbar plexus. And that's very common.
Which of the branches of the lumbar plexus?
Usually the general femoral nerve is the nerve that we often run into. Shot there?
So just
Okay.
maybe for the audience, what did you just put into the, let's call it into
So
the
we
hole?
just put
Just
a
two lights,
retractor
or?
in, and then hopefully you guys will be able to see what it looks like on the inside. And then I'm just opening the retractor blades. So once this K-wire, so now I can take this out, and then let me get suction, Steve. So I have a great assistant here. Steve Birnbaum is helping me today. And so let's get a shot there. So I'm on the lateral aspect of the disc, and then let me get a pituitary. So now you can see basically the size of a quarter, and then do you have a 15 blade? We're working through this channel. So you can imagine, what a game changer this is for patients. So you can, literally through the size of a quarter, do this procedure. Shot there. So now I'm cutting the disc space at L3-4. So I'm cutting the disc space above and below and doing what's called an annulotomy. So cutting a hole in the disc space. And then what we're able to do is take this disc out. And again, for me, my practice is I do a lot of trauma, tumors. So if you can imagine if you have a spine fracture, to be able to take out someone's vertebral body through a little cage, through a little retractor like this, and put in a cage in, and they can literally walk around next morning and that night. And the incision is very tiny. So now I'm in the disc space, so let's go ahead, Tyler, let's get a shot there. So you can see I'm in the disc space now, and then once I get the disc space open, then I put my other instruments, and each instrument that I put in here, we're going to try to open up this disc space. So now we're going to get one more, and then we're going to come around, Tyler, and get a X-ray shot there. So see this instrument? So now this has gone into the disc space, and then we're going to try to safely go all the way across the disc space. Shot there? Oh, sorry. Yeah, just a quick lateral. Great.
So do you take out the entire disc?
Yeah, so we're going to take out the entire disc, and then by putting this instrument in there, we're getting a sense of what direction the disc is going to go, and then we're going to take the entire disc out. And the key to this procedure is really what Dr. Tubbs was saying earlier, so we're a little anterior there, so what I'm going to do now is take the retractor and go a little bit posterior. Shot there, Tyler? And you can adjust this retractor, so go ahead and come around. So Steve, let's go ahead and adjust it a little bit. So you can see on my X-ray there, I'm pointing posterior. Let's go ahead and loosen it. So we're just going to adjust it because we want the cage to go in a little bit more posterior than the way I'm aiming. Okay, go ahead. And so now, great. And then come on back in, and you'll see just by doing the little adjustment in the retractor, now we can go posterior. And then, okay, and then get one more shot. Okay, so you can see, and then let's adjust it a little bit more. I need to go a little bit more posterior. Okay, go ahead and lock that. And then let's get the 6-box cutter. And so now what we're going to do, now that we know where our disc space is, we're going to carefully use these selected instruments to go back. And then come on back in, Tyler. So now we have another instrument. It's called the box cutter. And essentially it takes the disc out. And you can see it's got these sharp edges. So shot there, Tyler. Okay, perfect. So that's perfect position of the retractor. So let's go ahead and do a lateral. So the retractor position is everything. So based on where the retractor is where the cage is going to end up. And you can see that we're doing this through just a tiny little incision, and it takes very little time to do this. Okay, let's see the mallet. Great. And I remember when we first started doing this, just like any procedure, you really start learning the anatomy and the procedure, and you learn it by actually doing this procedure in the lab and practicing, because this is not a common. In fact, when I first started doing it, they didn't even have codes for this, so it was very difficult to get insurance companies to approve doing it.
How long did it take you to get comfortable with this procedure?
I would say it probably took me about 100 lateral procedures in order to get really comfortable. Great, thanks, Steve. And it's like playing football, huh, Ricardo?
For sure.
Practice makes perfect.
For sure. I was just thinking that if I was getting this procedure, that's a doctor that I would want. Dr. Rod Oskouian, in case you guys missed it.
So there's the disc. So we took out the disc. And then now my assistant is going to grab that. And then, so now what we're going to do is take out, so most of the disc is gone.
Rod, how do you know that you're not taking out some of the end plate?
Well, that can happen. So we use the fluoro machine to really guide us. Let me see a 10. Let me see an 8 box cutter. And then, so.
Do you change your technique at all if there's osteoporosis?
I try not to get in the end plate. Mm-hmm. And we treat every case like as if they have osteoporosis, because the instruments and the companies have done such a good job, shot there, of developing that oftentimes the tools are much more, they're more powerful than the spine. So you can see, so now I'm inserting this this trial in, and you can see it's actually distracting the interspace open. And what that does is that opens the nerve channels, and you can see that's going in. So I try to get it to go all the way across to the lateral part, and then what we're going to do is come around, and by doing this opens up the nerve channels. So a lot of times we'll do it for people who have failed back, has had multiple surgeries, and they're here for revision surgery, and so it's much easier to revise something through this approach. And you can see the placement of the implant there. So it's mid-vertebral body, and it's pointing posteriorly. Okay, so now let's come back around.
Is there any use in breaking the table when you're doing this level?
We used to break the table on every case, and I've kind of gone away from that. And I think part of it is that when you break the table, it does, so here you can see we got more disc material up.
What exactly is break the table? Because I'm pretty sure people at home, their definition of breaking the table is different than you guys.
It's a good question.
It's kind of like breakdancing. But what you do is you can move the table around, and the operating room table you can break it in the center.
Oh, okay.
So on the case like this, we would break it a little bit so that the patient's spine kind of gets stretched out. So it makes the procedure easier. So let me see, do we have a trial?
So is it possible to perform this procedure, for example, lower, like an L5-S1?
No, you can't do it at L5-S1 because at L4-5 you have your iliac crest, and that gets in the way. So so this procedure works really good at L4-5, L3-4, and further up. And you can go all the way up to about, the highest I've done is T6-7. Mm-hmm. This is an 8. Okay, so now this is like now we're going to put the trials in. So we'll try to see, let's get a shot there. So this is like a shoe. We're trying to see what size this patient is going to be. So this is an 8 trial. And you can see it's going in there nicely. And, we probably could use this. Let's see, should we try 10? Yeah, let's see, 10, Steve. So we'll try 10. And then this tells me, so the size of this actually is it's 8 millimeters in height. And then this one is 50 millimeters in length. So we know that that's probably going to be a 50 millimeter.
So do you try to fit it in really tight?
We try to make it so it's snug. And then these are what we call our slides. And so what we do is we then put the slides in, and this goes back to Dr. Tubbs' question. This protects the end plates from fracturing. So go ahead and put that in. Okay, great. So you have these metal slides, and then what I'll do is so here's the cage. You can see it's got bone graft windows. So we put bone graft in there so that eventually the bone grows over it, and then the spine fuses. So now we're going to go ahead and put this in, and then my assistant here is doing a good job of holding the slides. And then I'm going to point this posterior, and then you're going to see the cage go in. And then what this does is it gently distracts the inner space open. So you'll see, and now you're going to see the vertebral bodies open up. And this is the magic of this procedure, is that you can go in there and cure someone of their leg pain by opening up the nerve channels. And you can see just right there, just right before your eyes, that the spine is opening up.
How often does the cage move?
Shot there. Very little. I've had one, in my 10 years of doing this, I've had one cage dislodge, and I'm pretty sure that was the only time I've heard of. Very rarely do you see this happen. Let's go ahead and get a shot there. So you can see the implant is a little bit too far on the one side. So now I'm going to get this other instrument and pull it back just a little bit. You'll see. So I want to match the spinous process with the middle of the implant, and you can see it moving there. So there's 3 dots on the implant. So there's a dot in the middle that's supposed to match up with the spinous process, and then there's a dot on the other side as well.
Dr. O, what is the material of the implant?
So this is actually, it's called PEEK, which is a very hard plastic, and in fact, they manufacture this. It was originally used for airplanes. Go ahead and come around. And it's polyethyl ether ketone is kind of the manufactured name of it. But it's almost indestructible. And it works great on spine procedures like this. So now we're going to get a shot, and we're going to see here that... There you go. Perfect. And then you can see that's a perfect placement of the cage. So now we're going to go ahead and undo this. And then literally, so maybe that took 6 minutes. And we're going to get one more shot. And then you can see and you can see how it opened it up. So now what we're going to do is, let's go ahead and loosen the retractor. And you're going to... And then, so you can see me coming out, and then we're done. And so basically all the tissue now is coming back together. There's no bleeding. Come on in. And then you just put a couple stitches in, and you're done. And I've had patients go home the same day after this procedure. And
do you put any restrictions on their activities post-op?
We used to, but now we don't. I mean, it's really... Spine surgery's, kind of completely changed. We used to kind of have them do very little. We'd admit to everyone in the hospital, but now it's gotten so easy, and and the companies have all done such a good job with the instruments that the patients go home the same day or the next morning. And you can imagine, so let's say if you had a fracture, you could take out a vertebral body through the same incision, and the patient, in fact, my patient from Saturday went home on Sunday. So, you know, the time for people to heal and rehab, as Ricardo pointed out, is really a game changer.
Can you do multiple levels at the same time?
We do, in fact, you can, even on this case, you could do the next level and the level below it through the same incision. Sometimes we have to make a new incision. You just change your angle and your trajectory. So,
What's the most levels you've done at the same time?
I think I've done the most levels, probably 5 levels. I think I've done a 6th level all at once. So we did L4-5 all the way up to T11. And I think on that patient, I think we had 3 incisions.
And what decides for you which side you do, left or right side?
You know, typically we'll go from the left side, but a lot of times we'll go in, like if it's a patient who has a spinal deformity, we really study the CT scan and the x-rays, and then we decide which. Sometimes we go left, and then we reposition the patient and go from the right.
And the segmental vessels that are running over the vertebral bodies, that's never an issue?
You know, for doing, if we're taking out the vertebral bodies, we'll find the segmental vessel early, coagulate it. Sometimes you have to clip it because it's such a large artery that comes off the aorta. Sometimes you actually have to clip it. But whenever I'm doing a vertebrectomy, I always find the segmental first before taking out the vertebral body. And then just like we showed, we take the discs out and then we take out the vertebral body.
And any concern for Adamkowitz?
You know, knock on wood, I've never had any issues with Adamkowitz. I think, you know, there is the concern of having like a stroke in your spinal cord, but we haven't had any Adamkowitz issues doing lateral surgery.
Well, that's great, Rod. I think after seeing your proficiency there, I'd let you do XLIF on me right now.
Yeah.
Well, maybe we should take him up on his offer.
Let's do it. Half price.
For sure.
Great. Thanks, guys.
Yeah. Thanks, everyone.
Thank you very much.
Thank you, Dr. Oskouian, for showing us how to do the XLIF.
For sure. I was intrigued by that. I was locked in the entire time. Sorry, guys, you didn't get many questions from me. But this is for your educational purposes. This isn't for you to try at home. This is for you guys to know and understand the procedures that these guys do every day, and maybe some of the procedures that your family have experienced or will experience. And thank you for another experience at SSF Live. See you next week.
So we do a lot of these complex procedures at Swedish Neuroscience Institute. So if you guys want to learn more, come on over and see us at the Institute.